It's a pleasure to welcome you all tonight to the annual Lucille Austin Lecture. We honor the legacy of a great clinical professor, and this is the one occasion where I don't mind outing myself and my age to note that I had the privilege of studying with Lucille Austin. We're really delighted tonight to learn that her great-granddaughter joins us in the audience. I want to note that this is a terribly painful time at the Columbia School of Social Work for many of us here tonight, for reasons you all know. I'm asking that we put aside a multitude of feelings and viewpoints to focus our attention on our topic and the excellent speakers we have invited to share their expertise. Every year, our committee faces so many choices about topics. Each is a pressing clinical and policy and social justice concern. Tonight, our committee has chosen the opioid crisis. I want to thank our passionate alumni committee, Fran Friedman, Susan Neowith, Emily Jabbour, and the support of administration, especially Dean Begg, and Jean March, Associate Director of Alumni Relations, who's the glue for our tonight's event. Everything that works tonight is because of Jen. Now, please welcome Dean Melissa Begg, who will introduce our speakers. I'm confident that this is one of the few pleasurable tasks that she has managed in recent months.
Thank you, Sue, for that nice and thoughtful introduction. It's a hard time, which makes it all the more special that everyone chose to join us for this really special event. So thank you, everyone, for being here. This 2024 Austin Lecture celebrates the life and contributions of Lucille Austin, who, as Sue mentioned, was on Columbia's faculty for more than 30 years. We're extremely grateful to the Kenworthy Swift Foundation for their grant and a generous contribution made in memory of Jane R. Heimerdinger for the support for this event. I'm also so thankful to our outstanding committee of Alumni Association past presidents for bringing it all together. Susan Maturin, Frances Friedman, Susan Neowith, and Emily Jabbour. We have a great program right now because of the efforts that they devoted to this. I'm really happy for this opportunity to come together to share some ideas, approaches, and strategies that impact some of the great work that social workers do with their clients. And I'm proud of the interdisciplinary approach and the impact of the research of our faculty in helping to curb the opioid epidemic and related issues. But now I have the great pleasure of introducing our two spectacular speakers. First, our first speaker is Dr. Jonathan Avery. He is the Vice Chair for Addiction Psychiatry, the Stephen P. Tobin and Dr. Arnold M. Cooper Associate Professor in Consultation Liaison Psychiatry, and the Program Director for the Addiction Psychiatry Fellowship at Weill Cornell Medical College. Dr. Avery is a graduate of the New York University School of Medicine. And prior to joining the Cornell faculty, Dr. Avery completed an Addiction Psychiatry Fellowship at the same place, NYU School of Medicine. He has published on a broad variety of topics in addiction psychiatry, including papers on subjects ranging from clinician attitudes towards patients to how to use buprenorphine. He is the founder of the Weill Cornell New York Presbyterian Program for Substance Use and Stigma of Addiction. And his research on stigma is supported by several national grants and awards. He was on the editorial board for the DSM-5 clinical cases and is the editor-author of 10 books, including Co-occurring Mental Illness and Substance Use Disorders, A Guide to Diagnosis and Treatment, and The Stigma of Addiction, an Essential Guide. He has won numerous awards for his clinical and his academic work, including the American Board of Psychiatry and Neurology Faculty Innovation in Education Award and the Outstanding Faculty Member Award from the New York County Psychiatric Society. We are so grateful that you could join us, Dr. Avery. Also joining us tonight is my terrific colleague, Dr. Tim Hunt, who fills leadership roles in several important Columbia School of Social Work initiatives, including the Social Intervention Group, the Global Health Research Center of Central Asia, and CHOSEN, a new interdisciplinary university-wide center for healing from opioid and other substance use disorders. Together with his colleague and my colleague, Musher and University Professor Dr. Nabila El-Bassel, and many other wonderful colleagues, he is a co-investigator and lead for intervention and community engagement on the federally funded Healing Communities Study, which aims to reduce opioid deaths in 16 hard-hit counties across New York State, as well as in 3 other states, for a total of 67 different communities. To this crucial study, which was course, further complicated by the advent of COVID. He brings expertise in implementation science, knowledge of evidence-based strategies, and access to community partners through the strategic engagement of local leadership, criminal justice and law enforcement, and emergency and treatment settings in a community-centered and equitable data-driven intervention called Communities That Heal. Dr. Hunt brings over 30 years of clinical experience as a family and couples therapist, licensed clinical social worker, research scientist, and addiction specialist. And as a testament to the reach of his work, he has trained nearly 10,000 healthcare and social service staff working with families, children, groups, and individuals. Dr. Hunt holds an MSW from NYU, is a postmaster's grad from the Ackerman Institute for the Family, and he received his PhD from Columbia University. We're proud that he's an alum and he's an outstanding scholar and a wonderful colleague. So please join me in welcoming both Dr. Avery and Dr. Hunt.
Thank you, Dean, for the kind introduction, and it's a real honor to be here for this special series. There, you're seeing my slides now. Perfect. And it's very special to be joined by Susan Matter in this, who's been such a wonderful colleague, supervisor, mentor, friend over the years, and as I'm sure she has been to so many of you. And so it's really special to be here sharing my work on the stigma of addiction and talking about some of the things we can do to combat this opiate epidemic together. I think it's an incredible topic that will hopefully bring us together in this difficult time. And I wish I could be here in person, but I'm happy to be able to do this on Zoom. I'm going to speak and then I'm going to get out of the way as soon as I can for Dr. Hunt. I'm really honored that he's following me and his work has been transformative. I love how he shows how evidence-based work can get out into the community and eradicate stigma, which I think is one of the biggest barriers to the combating the opiate epidemic. We've thrown tons of money into solutions to the opiate epidemic and it rages at record levels. And so that's why today for my talk, I'm going to be taking it out primarily by focusing on the stigma of addiction, especially as it exists in the places that should be the safest among clinicians, in the medical community, but even among lawyers and our family members. We'll talk a little bit about its role in society overall as well. And I think social workers in particular play a unique role in helping to engage families and patients as they intersect with their community. And so I think the stigma is important to pay attention to. Just a reminder at the end, so we'll have a question, both of us will talk, we'll have a question and answer, and then at 7:30, I think you have to go to complete your CEs, but it's very much worth it because I'm going to have two people that come with me to help combat the stigma of addiction, John Sitcher and Robin Kellner. They're going to tell their story about losing their daughter to this opiate epidemic, and they're going to help me complete the day by doing a Narcan training, a naloxone rescue kit training. There'll be 10 to 15 minutes at the end, go over the basic steps to learn about Narcan, and then you'll all receive it in the mail afterwards. All right, let's get started. My work is supported by a couple of national grants. This is the active one through the Foundation for Opioid Response Efforts, and they primarily helped fund this research. I'm going to show that using effective technology to improve attitudes towards folks with opioid use disorder. I also have the Browse Family Award, which supports my work, and the Stigma of Addiction book that a lot of this is taken from. I did co-author with my brother, who's a psychologist turned lawyer, now at the professor at the business school in Miami. You can Google him and find that he looks like me, but with hair, but you don't have to tell me that. Everyone feels the desire to tell me that, but I know that he has hair and I don't. So those are my disclosures. So I'm going to talk a little bit about the opiate epidemic, where we are in terms of the escalating numbers. Then I'm going to discuss the stigma of addiction as it exists in society and among clinicians. And then we'll think of some efforts to improve that and some efforts to combat the opiate epidemic, which I think will lead in nicely to the things Dr. Hunt is doing to really take us over the edge. And so the numbers are staggering. This data is only to 2021, but it's only gotten worse with over 100,000 deaths in the last year. And a lot of this is due to this third wave of the opiate epidemic, where it started, first with doctors overprescribing opioids. I broke my foot in the late 90s. They gave me 180 Percocet for my foot injury. I only used one. I don't even know where the other 179 went. Pain was the fifth vital sign. You couldn't go wrong prescribing opiates. We eventually started cracking down on that. People turned to heroin. Eventually, complex mechanisms conspired to have this surge of fentanyl being brought into the country. And now a lot of the overdose deaths are because of fentanyl contaminated product. And concerningly, this is fentanyl contaminated product of opioids, things like heroin or prescription pain meds that you think you're getting an opioid. But concerningly, fentanyl is present in a lot of other substances, including cocaine, those marked as Xanax. We had this big Adderall shortage in New York City. I'm not sure if any of you heard of it for folks with ADHD, but a lot of my students, a lot of people locally were then trying to score stimulants on, not from a prescriber. And we had a record amount of young adults coming in with what they thought was Adderall overdoses, but was opioid contaminated Adderall product that they were getting. And so, this is a tricky epidemic to counter as this powerful opiate is contaminating the drug supply. Basically, the saying is that anything that doesn't come from the pharmacy carries the risk of fentanyl contamination these days. And you can see some of the health alerts that the Department of Health is putting out there. But this contributes to this staggering number of deaths. Concerningly, it's impacting minorities at an alarming rate. Non-Hispanic Blacks, Hispanic, non-Hispanic whites, this is impacting everyone, driving down the life expectancy of Americans. But it especially hits groups that have been hard hit due to another number of other factors. And it's impacted minorities, it's impacted women more than men. 20, 15 years ago, addiction felt like a man's game. Mostly men were presenting to treatment. We've never seen more young women presenting for care for opioid use disorder in the last couple of years. And certainly much has been made about how the COVID and all the recent factors of last year have escalated substance use in women overall. And in general, we're in this time where substance use is really high. I mean, alcohol use is at record highs in a lot of ways, responsible for about the same amount of deaths as opiates, impacting women, men, minorities at record rates. We have the youth vaping epidemic, the overprescriptions of benzos. Addiction is everywhere, and we need to be talking about it and addressing it all the time. But opioid use disorder really is our red light emergency. In the world of addiction, we think of all substances of abuse on the one hand and opiates on the other. And a lot of the reason for that is in terms of how opioid use presents, with this real risk of sudden death and accidental exposure to something that could kill you. And it's those deaths that really make us all have to be involved and ready to tackle this, no matter what type of clinician or community member that you are. I mentioned there's benzos, there's huge economic cost to all of this. And so, no one's immune. And so you would think, and I thought, I sort of knew I wanted to be an addiction provider from the beginning. I had, friends and family members struggle with substance use. And, I came into medicine thinking that everyone would be on my side. Like, this is something we really need to combat. And very quickly, I learned that very few people shared my enthusiasm for working with folks with substance use disorder. And I was told many times along my developmental trajectory to not be an addiction provider. It wasn't worth it. And I suddenly realized this stigma, which I had sort of understood a little bit as a community member, I further understood as a clinician and as someone who was learning about addiction, and realized that it is something that is everywhere. And when we talk about stigma and addiction stigma in particular, what I'm talking about is these negative attitudes that exist towards individuals with substance use disorder that arise on account of the substance use disorder itself, but two, are likely to impact the physical, psychological, social, or professional well-being. And I've done a lot of studies characterizing these attitudes towards substance use disorders, and they're survey responses. They're subject to this medical condition regard scale, which characterizes the attitudes. But they're generally readily well accepted. A lot of the debate, and maybe it's a debate to have today in the question and answer, ends up being on people not believing in the disease model of addiction, or that it's a health condition that deserves the same respect as other health conditions, or at a minimum that when people use, it's incredibly difficult to change use just because of the way the brain is hijacked from substance use. And opioid use disorder, we know, is especially sticky, causing neurologic changes that can last a lifetime and that only abate after a long period of abstinence. Yet a lot of people view it still as a moral failing. bad people doing bad thing, or feel that people have overemphasized the role that the disease model plays. And so at times people just like to argue that. And because of that, I feel that that rejection of it as a health condition that deserves our attention and shares, traits with all these other health conditions that we're tackling is one of the primary drivers. And it's something to keep in mind, especially in the opiate epidemic, because the opiates are so sticky. You have people that take opiates and they say, whoa, for the first time, I feel normal, I feel right. Something clicks in them the way nothing has clicked before, and it takes over their reward pathway and tons of circuitry throughout the brain in a way that makes change really hard. And it's why it deserves all of our attention. There's a lot of good books on how we got here from the opiate epidemic. If you haven't read Dreamland or Dope Sick, I would definitely pick that up. I think you can't really be a clinician until you've read how we've been here, how we've gotten here from the opiate epidemic. And then read about the brain disease model of addiction. I think these are a couple authors that characterize a lot of the factors that go into the opiate epidemic and substance use overall. But there's plenty of good resources out there, and it's important to know about the brain disease model of addiction. All right, so I'm going to talk a little bit about the stigma that exists in society, jettison to the stigma as it exists among clinicians, and then we'll talk about some solutions that we can do to combat the stigma, but also some of the treatments that we can bring to the lives of folks that are struggling with opioid use disorder. In terms of stigma in society, I love this quote: Americans love drugs, but hate the people who use them, especially if they are poor and or not white. We send those people to prison. And so, the stigma as it exists in society exists on multiple levels. The media does no one any favors in terms of how they characterize folks with substance use disorder. I think they did a decent job with Matthew Perry and talking about some of the factors that went into his life and his eventual overdose and passing. But mostly, they're dramatically blaming the individual, scaring people, over-exaggerating things in a way that makes nuanced discussion very hard. I mean, that could be applied to the media and any of these things that we're going through as a society, of course, and addiction certainly doesn't get a pass. The New York Post is probably the worst of all the offenders in terms of how they make us think about folks with substance use disorders. Their articles tend to be as dramatic as this one: New York drug crisis reaches new lows with addicts standing around with needles hanging out of their arms. They're meant to scare and to distance ourselves from them. And a lot of how we distance ourselves, both as clinicians and as a society and through the media, is by the language that we talk about folks. We should be describing individuals with an opioid use disorder as opposed to addicts and junkies, and even the clean and dirty language. A lot of this gets in the way of sort of recognizing that it's a health condition, that it's a disease that deserves our empathy and our attention, just as all these other conditions deserve our attention. Throughout Hollywood and the media, there's some better efforts these days to be more nuanced, and sobriety has more of a more currency these days than ever, but still there's just an incredible lack of nuance. Where the opiate epidemic disturbingly intersects with other biases we see as it relates to race, especially, and racialized drug stigma, and especially as it intersects with opioid use disorder, as we talked about, the numbers is especially problematic. And there's been a number of studies, not just these, and a lot of my colleagues are working to combat this, but you can see participants assign greater blame to Black individuals who develop drug dependence as compared to white individuals. And these attitudes that exist, we end up associating violence and dangerousness and criminality with folks who are using opiates, as opposed to viewing them as some people who are struggling with a mental health or substance use disorder. And we have all these attitudes that permeate society and in our professional life. My brother, I mentioned, was a lawyer turned psychologist, and together we looked at the intersection of the legal system, addiction, race, and stigma as it related especially to opioid use disorder. And we took a look at a lot of folks that, one of the issues is that we disproportionately put people in jail for drug offenses as opposed to offering them treatment. And we looked especially at how people that should be on the team of folks struggling with addiction, their criminal defense attorneys, felt about their patients with substance use disorders. And, not surprisingly, the attitudes were negative. Concerningly, you can see it's not a very diverse group, the lawyers. They're less diverse than doctors and other clinicians, primarily white and male, even today. And, we would ask them, we did a number of studies with them, but one of them was asking them the degree to which they agreed with the disease model of addiction, all the way from addiction being a chronic relapsing brain disease to addiction primarily reflects a moral lapse. And not surprisingly, the degree to which they agreed that addiction was a brain disease, the more positive their attitudes were towards the person with substance use, the less likely they were to believe they would offend again. And we think that translated into better care they received from lawyers. So there's the stigma throughout society, is what I'm trying to say here. There's the stigma in the media, in Hollywood, in as it intersects with race and the legal system. There's stigma at work. These days it's easy to come forward with mental health issues or cancer or other conditions. It's still very hard to go to your employer and say, I have an opioid use disorder and a substance use disorder and I need help. And this is in the setting of the opiate epidemic, and it remains very hard to get help that's supported by addiction. The stigma exists in family members, families implicated through bias, all these terms, enabling, codependent, they create this idea that family members are to blame. And you'll hear it in the story of the family at the end, and Robin and John talk about how stigma impacted the care of their daughter in her battle with substance use. The Mexican president blames U.S. federal crisis lack of hugs among families. I mean, there's just so many ways that family members get blamed. And I mention this because it's important, because all this public stigma leads to self-stigma. If everyone around you is telling you you're bad, you're a failing, from your family to your job to the legal system, you start to believe that you are those things, that you're a moral failing, that you need to hide this, that it's something to be shameful of. It's not like another health condition that you can be open and honest about. And so sometimes clinicians will say, I can't understand why my patients lied to me or don't tell me the truth or hide their substance use from us and their family. Given all the stigma, you would be nuts to tell the truth. I'm alarmed when people come and they tell me the truth and they've been struggling with substance use, because everything is positioned in a way to make people want to hide their addiction. And so, of course, this situates people in a place where recovery is made even less likely and more remote, decreases willingness to involve others and seek treatment, and impacts, in return, work, family, friends, and relationships. And so a lot of my research has been focused on how doctors and clinicians, social workers, I'll show one study involving social workers, aren't much different than anyone else. I think we think sometimes when we become these clinicians and these healing professions that we're immune to all these biases, but we need to acknowledge them because we bring them with us. And my primary finding is that clinician attitudes are worse towards individuals with substance use disorder than towards individuals with any other medical or psychiatric condition, and that these attitudes get worse over time. And we've demonstrated this largely using the medical condition regard scale in a lot of different clinicians. I won't go through all these studies: psychiatry, ER, internal medicine, even in addiction communities, adolescent providers, pediatricians, all these clinicians that you think would be on the front line and the ones that would help us tackle this have negative attitudes. My study is similar to this study, which included social workers and was this huge European study. And it showed, like-minded, that attitudes were worse towards folks with substance use disorder than towards other medical or psychiatric conditions. They were worse towards those who use drugs and opiates than towards alcohol. And my research as well has shown that attitudes are worse towards folks who use opiates. And then concerningly, attitudes are negative to the treatment for opioid use disorder. Dr. Hunt and I are going to talk about how the treatment involves medications for opioid use disorder and harm reduction efforts like the Narcan kits you're going to get at the end, and that they have this really robust evidence base, some of the most successful medications we have in medicine. And yet there's these attitudes amongst society, even among clinicians, that giving someone a medication to help with addiction is not really being in recovery, or that recovery is only through 12-step, or there's all these sort of biases and these ideas that this is the right way. And I feel like this stigma towards these folks and towards the treatments is a large reason why we haven't made a dent on the opiate epidemic, why it's getting worse. And Dr. Hunt will offer a great solution to this. And of course, stigma in the medical community is bad. Why do I think there's stigma in the medical community? Well, why is it among us? Because, as I said, we're not different than anyone else. If the data is right, if there are can't see how many people are in this room, 75 people in this room, 20 of us struggle with substance use disorders ourselves. A third to 2/3 of us have substance use disorders in our family. There's this sense we learn from society that it's other. And then there's also this aspect that, hey, it's too close to home, that it might impact us in the same exact way. 1 in 10 doctors and nurses have substance use disorders. We learn a lot about the neurobiology of addiction. I've shown that even doctors don't believe that. We learn all about all these things have been hijacked, and we see the imaging studies. And when we ask them those same questions we ask the lawyers, doctors more than lawyers endorsed addiction to be a moral failing. If you're worse than lawyers, there's a problem. That's a general life rule. My brother's a lawyer. He'll tell you the same. And not surprisingly, the attitudes were, as a consequence, the more you thought it was a moral failing, the more negative your attitudes were. I don't think we're so much better on language. We're doing this big study now here at the hospital when we're going through all the charts of all the clinicians in the hospital to see where the most stigmatizing language is. And we were going over the data today, interestingly, and there were two groups, the ER doctors and actually social workers, and more female than male, that used more stigmatizing language in the charts. I think the reason ER doctors have negative attitudes, and it might exist among social workers, is that you guys are on the front lines where you're seeing people in these really acute, intense states. And it's hard sometimes to, especially in the hospitalized setting where we were looking at, to have hope, because it feels sometimes like you're seeing people come in and out. And that's part of why attitudes get worse over time, especially in these acute care settings, is that you're not getting the wins. We know most people that present to the ER with opioid use disorder will be in recovery one day. As much as the data is made about the number of people struggling, there's 25 to 50 million people strong in recovery in the United States. But sometimes we lose sight of the recovery community and how strong it is. Certainly the lack of knowledge. We're talking about why we might have negative attitudes even as clinicians. Certainly feeling like we don't have the knowledge, the skills, the resources, the time, that all plays a role. The complexity of these patients plays a role. We're also not immune to racial bias. And I talked about how these repeat negative experiences, sometimes we lose track of the whole narrative, that people get better and that there's a lot of good options for help out there. And certainly there's this thing that we talk about in stigma called the hidden curriculum, right? You learn from your teacher that you should not see people with substance use disorder, don't work with those families, or should prioritize other people in the hospital over folks coming in with substance use disorder. John and Robin will say, and they'll probably say today, I mean, how sick do you have to be near overdose state? I mean, that's as sick as you can get, and these folks deserve our attention and support. I feel like I've been a bad news bear this first 15, 20 minutes, but there's a lot we can do. And I think a lot of things we're doing better to improve stigma and to combat the opiate epidemic. And so we'll shift to some of these things. And, I have a number of ideas around how we can improve stigma. I'm curious to hear your all thoughts on ways that we can do this among the places that you work. But I think to start, we need talks like this. We need so I'm so grateful for Sue and for everyone for inviting us. You need to increase awareness of and interventions for stigma, adjust clinician substance use and racial bias, increase knowledge and skills, policy changes, spread the word. And so the general recipe that we've used over the years is that we, and I'm really proud that it was translated to done in the Middle East this year, and Jefferson, and sort of our playbook that we have to combat the stigma is increasingly being used by a lot of medical colleges and organizations around the country and around the world now, is that we have sort of an hour introduction to substance use disorders, what it means, what are some resources, what are some practical things that we can do. We then have someone talk about stigma and their personal experiences. We have patients, and John and Robin do this for me, talk about their experience with the opiate epidemic. And then we have some interaction around it. So it's really an awareness intervention. And we do this all the time here at Cornell to all different groups of providers. We do it 8 consecutive weeks in small groups in January, February to internal medicine residents. We do it for the med students. And we've demonstrated that they've been very effective, no matter where we've done them, including we recently published how this was translated to the Middle East and North African clinicians, and they were able to do it in Qatar, which we were really proud of. We've distilled my entire talk today to 7 minutes in this video, www.substanceusstigma.com, which makes me wonder why I'm talking so much right now. But this video is goes through a lot of the things we talk about, has folks talking about their struggle with substance use and how stigma is viewed, and offers some solutions. And this is that's been, I know no one likes hospital trainings and all these annual trainings, but this has been incorporated into ours here at the hospital, and we've demonstrated among psychiatry and internal medicine residents that improved attitudes towards alcohol and opioid use disorder. The latest thing so one thing about interventions for attitudes or about changing behaviors around prescribing for opiates, or people are a little tired of being finger wagged at by people like me, and so we're trying to come up with new, interesting ways to engage people around stigma. And one of the things we're learning about is how to use technology. And I was lucky to partner with Rosalind Picard at MIT in their media lab, and we're working on these skill-based solutions to stigma and bias. And what Rosalind Picard does with effective technology is she teaches you how to have non-stigmatizing face. Because the reality is that we're burned out as clinicians, we're overwhelmed at times, and we have to be very aware of our body language and how we're feeling and expressing ourselves, regardless of how we're feeling on their days, especially to groups that are sensitive to feeling judged. And so, even if you don't have bias towards someone with opioid use disorder, they're coming in, nervous because of all the stigma they've experienced. And there are practical ways that you can learn how to present yourself as empathetic and open and understanding. And it can seem a little gimmicky, but her research has shown over and over that it can really improve people's experience of you, but also improve how you feel internally. That is, if you can learn how to appear empathetic, you can learn how to you can feel empathy, and it can really improve things. And so let me see if I can turn this so I can see my face directly. So, I mean, one of the big findings is that the most empathetic face you can make, just to show you, and you can practice this at home afterwards, is to raise the eyebrows slightly in the middle and to have a slight non-smiling face. So that's sort of the most empathetic face you can make. And what this module does that we created called Medship, and we've just wrote about it for academic psychiatry, is it sort of teaches you about stigma and how you might express it on your face. This app also teaches you about the stigma of addiction, has that video that I mentioned before. And it's this is Adana, who works with me, trying to appear to have a compassionate face, but coming up sad. And so it teaches you, how to sort of present yourself in a way that's open and understanding and compassionate. I mean, you talked a lot about bedside manner in clinical settings, but there is a facial bedside manner to be aware of, especially in groups that are prone. And then especially in the world of telepsych, like this technology is being used in Zoom settings, in digital health platforms, to quality control people's engagement with folks, because it does let you know. And so what we did through this module is we teach you how to have these expressions, and then you go through a clinical scenario with a patient with opioid use disorder, and it teaches you it analyzes your face and gives you feedback on the degree to which you are making empathic faces. And it's sort of a game, but it's to highlight in a fun way the importance of being aware of a bedside manner and stigma in folks with opioid use disorder. We're on to ways to combat stigma and to address the opioid epidemic. I think those interventions are important. Talks like this are important. Hearing the work Dr. Hunt's doing is important. I think we have to address our own clinical substance use. I think we sometimes neglect ourselves in all this. And as I said earlier, we're more prone to substance use than our age-matched peers, but we do well. Certainly these interventions need to exist alongside interventions that address racial bias and other biases that coexist with substance use disorder. We certainly have to reduce disparities in the healthcare workforce. We need a diverse group of folks meeting people where they're at. And that would include, I think, not shying away from hiring and promoting people with histories of substance use disorders. I wonder what the club social work school does when they learn that someone has struggled with substances. Is that a reason not to accept someone? And I think that is a common mistake we make, is because these folks are the best among us, and they've struggled with a health condition like many of us have, and have learned a lot. And I think some of these attitudes haven't shifted, because at times people do weed out folks that have struggled. I hope that's less true these days. But I think part of a diverse and comprehensive healthcare workforce is that we need folks with all sorts of backgrounds, including history of substance use disorders. We certainly need more people trained in addiction. We need a positive hidden curriculum that promotes that. We need to increase knowledge and skills, increase education about substance use disorders, learn more about the biological underpinnings of addiction. And then I would recommend to this group that you're learning all sorts of skills as part of being a clinician. If you haven't learned motivational interviewing yet, I would strongly recommend it. I think it's critical if you're interacting with any patient, but especially folks with substance use disorder, because it teaches you how to not go into a situation wanting to save the day, but rather meeting people wherever they are in their healthcare timeline, offering them resources, and in a non-confrontational, comprehensive, collaborative way, getting change talk to come from the person. I think at times when we see people with substance use disorder, we're prone to do what a lot of people do in the lives of folks with substance use disorder. We say, why are you doing this? You're hurting your liver, your kidney, your spleen. There's incredible risk of overdose deaths. You're going to die. You've got to stop this. You see the suffering you're causing your mother or your father. And the problem with that approach is, as I was saying, what's everyone in the life of someone with a substance use disorder telling that person? What's wrong with you? You're going to overdose, die. You're going to hurt your liver, your kidney, your family. Anyways, what's everyone with a substance use disorder telling themselves? What's wrong with me? Why? No one grows up and wants to be the best opiate use person on the block, right? So why am I trying to hurt myself in this way? And it's just so sticky with the disease model. And so I find that if we double down on that, we can push people into the shadows and further the stigma that exists. And so I would definitely recommend you take a course on motivational interviewing. There's a lot of great free ones these days. The American Society of Addiction Medicine, the American Academy of Addiction Psychiatry, they all have nice resources on their website. There's good books. It's the reason I don't get burned out as an addiction clinician, is that MI approach. The other thing to know about opioid use disorder, I talked about it at the beginning that, one reason opioid use disorder is different than other substance use disorders is the risk of death. The other thing that really separates opioid use disorder from other conditions is that you really need to be on medications. And primarily buprenorphine, methadone, or long-acting injectable naltrexone called Vivitrol. That's the strongest evidence base. And so and there's also good meds out for tobacco, for alcohol, for a number of other conditions, the risk of not being on these medications for opioid use disorder is death. The relapse rate at 1 year approximates 100% without these medications. And so that should also be your all red light emergency. Like, there's a way to work with people that are struggling with alcohol and weed and other substances to motivate them and use your motivational interviewing to get them to connect to care. But when you see opioid use disorder, you need to highlight, look, this is a disease that could kill you. And there are good evidence-based medical solutions that are stigmatized, but are potentially and are in fact life-saving. And in fact, some of the best data we have for any medication in medicine is for the medications for opioid use disorder. And the entrance point to care is often, not your doctor. And so we need everyone in the community sort of letting people know that, this is something that there are medications for that can help and improve outcomes and function. All these meds improve opioid use, overdose risk, mortality, heavy drug use, employment, family stability, pregnancy outcomes. They're safe in pregnancy. You can breastfeed on buprenorphine or methadone. The safety is there and the efficacy is there. And so we should be getting these into the hands of folks who are struggling, and at least letting patients and families know about the risk with these. The other notable point of people struggling with opioid use disorder, and I think an antidote to overdose deaths, but also to stigma, are giving out naloxone rescue kits and fentanyl test strips and xylazine test strips. We've done a lot of Narcan training. We've had our program up since 2015. Again, thanks to John and Robin. There's a picture of us at the Whitney. They'll be the ones doing the Narcan training with us at 7:30 today. But this act of letting people know that opiate overdoses can lead to death and that there's a solution, naloxone, which I'll train you all on at 7:30, is transformative. I think you should all carry it in your office, carry it with you as you go home. I mean, the Surgeon General said everyone should be having these kits, and it's an important message to our communities, to our family members. And it's not a treatment for opioid use disorder, but it's critical to keep people alive. And it's needed to connect people to care. There's no care if you're not alive, and we'll go through this more at 7:30 today. And as I mentioned, this improves stigma. When we started in an Narcan program in our emergency room, I mentioned ER doctors have some of the worst attitudes because they're in the thick of it and don't get a lot of wins. It showed that pre and post training it improved their attitudes towards folks with opioid use disorder. The other intervention that's pretty easily accessible, the Department of Health is dispensing them all over the place, are fentanyl test strips. This is a strip where you can test the substance that you're using to see if fentanyl's in it. If you're seeking an opiate these days, heroin, prescription pain meds in the community, it's fentanyl. I worry less. You should know you're getting fentanyl. You almost don't have to test them. It's fentanyl. These are especially helpful, though, for your weekend warriors, for people that are using cocaine, those marked as Xanax. It's a reminder that they might be contaminated with opiates. You can test to see if they're present. And it's a strong message to not use alone, to have Narcan, to know that you might be using something that's dangerous. I think there's around 10 overdose deaths in New York City right now. About 5 are from folks who are unaware that they're ingesting an opioid. And so it's important that we test our product and our substances so that we know how to be safe. I think the other important things to do to combat stigma is learn from the recovery community. They're 25 to 50 million strong, and they can be a part of our treatment. And certainly listen to the families, which is a big part of the Narcan training. And then I think we need a lot of policy efforts to help combat it. And then certainly all need to be talking about addiction and stigma overall. So some thoughts on what we can do to combat the stigma of addiction, to combat the opioid epidemic, I think are to increase awareness of and interventions for stigma, address physician substance use, expand the training programs, increase knowledge and skills, and then certainly be aware of these unique interventions that exist for opioid use disorder. For future directions, working on further understanding stigma and clinician attitudes and using technology, and then listening to Dr. Hunt, because it's a wonderful transition point. He's done such amazing work in getting evidence-based care out there, and I am thrilled to be able to turn it over to him to talk about his amazing work. Thank you.
Thank you, Dr. Avery. And thank you for not listening to the advice not to go into the field of addiction. I appreciate your work, your research, and certainly this work in the area of stigma reduction. Thank you so much to Susan and the committee for this invitation tonight. What an honor to be able to discuss and describe some of the work that we've been doing in this particular study, the Healing Community Study, where we're engaging communities. So I'll be focusing a bit on this particular example, in which takes some of the recommendations of Dr. Avery and really talks about how it's put into practice, but also in a research study. And so I hope for those, thank you for joining us tonight, whether you are a practitioner or you're in training or you're a student or you're an alumni, that you can take from this presentation tonight, not only the opportunities as a social worker to engage in addressing something as serious as the overdose crisis, but as maybe a researcher, that you have a role to lead in the field in addressing and engaging communities and solutions together. And this is one example of that, which I've been honored to work with my colleagues across 4 states. So very particularly, I wanted to, first of all, acknowledge that I'm going to give a brief overview of the study itself, some of the early findings or lessons learned, and hopefully we'll have time for discussion around areas that you're particularly interested in or maybe inspired by. And I appreciate the plug for motivational interviewing from Dr. Avery as well. It's certainly an important skill and evidence-based model and style in which working in communities, and we have to think about that even today, unfortunately, in our online presence and our video screens today, whether we're showing empathy. I first want to acknowledge as we do any presentation or talk around opioid crisis, that we acknowledge those people who are directly impacted, those families, those networks, those people living with substance use disorder, those who are examining their own substance use and whether it's problematic or not, and also the communities in this particular studies, our partners, the coalitions in the 67 communities across the 4 states. I have been so honored to see people in their work inspired, driven, addressing the issue on top of COVID, because we launched in 2019, addressing overdose at the same time. It's been an amazing experience and inspirational, and certainly helps me, Dr. Avery, from not burning out, because it is the people and the stories that keep me invested in this particular work. And thank you to our PI, Dr. El Basel, and the team of, actually, we have several hundred investigators working with us from NIDA and from SAMHSA. I did just want to emphasize, as you saw the stats from Dr. Avery around overdose, I want to emphasize again the disparities that he mentioned very specifically, that we're seeing a growing inequality among those communities of color, especially in Black communities, from Native Americans and Hispanic, that there is a growing problem here when it comes to overdose. And there are several factors that are contributing. We have to look more closely at those social factors, so the social drivers such as employment, housing, access to healthcare, and even looking at structural issues such as segregation, over-policing, and those kind of structural factors that impact whether someone accesses care or is even distrusting in care, that keeps them from seeking help. So in this particular study, the Healing Community Study, or Help End Addiction Long Term is what HEAL stands for, we tested an intervention called the Communities That Heal intervention, which was an adaptation of the Communities That Care intervention. We began in 2019 with funding from NIDA, along with SAMHSA, the National Institutes of Drug Abuse, as well as the Substance Abuse and Mental Health Administration. In 4 states, we were awarded. Columbia University was lucky enough here to be to lead the study here for New York State. And as you see, the study populations we addressed across the 4 states was around 8.2 million people, with the goal of reducing overdose deaths. We also wanted to increase the utilization of Narcan or naloxone distribution and overdose education. We wanted to increase access to medications that you heard Dr. Avery just speak about, medications for opioid use disorder, and also decrease the high-risk prescribing for pain and other elements, or multiple pain relievers that lead people sometimes to overdose. You see the population we address in these particular 4 states range from the highest population of 5,000 to the lowest population of 875. One, partially because of the 67 communities, which are divided by both rural and urban as part of the recruitment process. There were 11 communities that were identified from municipalities rather than counties in other communities. But also the overdose rates, as you see, a range, also per 100,000. And also the access to Medicaid and resources were considered in the engagement. Here we are in the timeline for those who are interested in research designs. This particular one is a mouthful of multi-site, parallel arm, cluster, randomized, waitlist control trial. What does that mean? At least we're going to be able to compare 2 arms, a wave 1 and a wave 2 arm. Wave 2 was a treatment as usual arm or wait list, and that meant that all of the counties or communities got the intervention at some point in the trial. And then we were able to compare the uptake of evidence-based practices and overdose prevention, compare the 2 arms. Here we are at the end of 2023, both waves received the intervention, and we are now in sustainment period, but also now we're doing analysis and writing, and the primary outcome of the study will come out, I would say, probably in the next month. And we've already written over 40 papers from this particular study. There are many different outcomes. One I'll be discussing today is stigma reduction as a result of this intervention. There are 3 primary components of the Communities That Heal intervention. Really central and something that is at the heart of social work is community engagement, the power of engaging communities in defining problems and actually coming up with solutions and coordinating those solutions. This is central to the intervention through coalitions, through a data-driven approach, making sure that there was broad representation from the community to implement the second component, which was this menu of options of evidence-based practices and strategies that supported those, called the opioid overdose reduction continuum of care approach, or ORCA, as we call it. And I'm going to point to some practice guides. They're available to you who are interested in those. At the end of this presentation, you can see those on the SAMHSA as well as our own websites. And finally, the third core component was a communication campaign addressing a stigma, awareness around opioid use disorder, awareness around treatment options, and looking at those evidence-based practices and trying to build awareness and access to those, driving people to resources, to websites that they could actually seek help for themselves or for their loved ones. The intervention is a phased approach. It is a 6-phase with sustainability from day one being considered as communities were engaged. At phase 0, a lot about defining the problem, looking at the local data, doing a landscape analysis, moving into your phase 1 coalition building or adaptations, using a rubric that we provided, making sure they were the right stakeholders at the table, including people with lived experience, living experience, as well as from communities of color or those usually underrepresented minority populations, moving into training around the evidence-based practices, the communication campaign being refined with defining the audience using data and visualizations, including a dashboard in those communities to develop the localized picture or community profile of what is the extent of the problem and what are the solutions and resources we can use in our particular community. An action plan was developed for each community, and then in phase 5, implemented with technical assistance and monitoring. And we also assisted in data collection where they were capturing reach. Are we reaching the target populations we were intending to reach? Our particular model in New York of community engagement really valued the local anchor organization or backbone organization, which was a county health department or a mental health or behavioral health department. We provided funds so that they could hire staff for the implementation team, which is a strategy known to be effective where we combined a program manager, a community engagement facilitator, and make sure there was data or EPI available. They helped to not only collect the data, assemble the data, but to help to visualize it. And we saw lots of adaptation and adoption of data-driven approach. Many of our communities says, we have a lot of data, we don't know how to use it, we need assistance, so help us do that. And so we did, as well as bringing in things like OD Map, which tracks fatal and non-fatal overdoses. They begin to use those and actually visualize those in websites. The coalition membership, as I mentioned before, making sure there was sector representation from behavioral health, from the criminal legal system, as well as healthcare specifically. And then those communication campaigns, as I mentioned earlier, making sure there were champions that represented communications as well as lived experience, and all the evidence-based practices were represented. A champion was the one who would face the problems, the barriers, the stigma, if you will, also, and they would face them head on. And when people got discouraged, they were the ones that cheered on the efforts. Now, community engagement in general, we know, is an evidence-based model. In social work, it has been our hallmark. It's a technical approach to directly engage local populations in the decision-making and planning and policy that needs to be engaged to address a particular problem. In research, we've done it along a continuum. Sometimes we just consult our community and say, what do you think about this idea? And other times we say, you will join us with equal leadership and decision making. We'll share the funds. So along this continuum of community engagement, we have had to address it. The healing community study, I would say we kind of hit toward the middle. It was much more about collaboration, actually. And we could have done a better job, I think, in the beginning by engaging them, even in deciding which particular intervention to use. But we got better at it as they were central to deciding through coalitions what evidence-based practices that they would actually decide on. The collective impact framework, some of you may be interested in. I'm very excited about this particular framework, which really was the the foundation of our intervention, was coming together with a common agenda, making sure we had mutual reinforcing activities together, that there was always continuous evaluation and communication, and that there was some backbone, as I described earlier, that were helping bring together the coordinated efforts of a community. I believe this can be applied not only to the opioid use disorder, but it can be applied to many different health conditions, including maybe HIV, STIs, maybe violence, maybe when it comes to criminal domestic violence or intimate partner violence and other particular health and public health issues. Bringing together stakeholders across a community, making sure they have a voice at the table, that they're heard, that the shared decision making, and that resources and allocation of resources were shared through that decision making process. What we found that coalitions tended to be between 25 to 40 membership, making sure the leadership was either from the community, the departments of health and mental hygiene, along with the program managers and community facilitators. Again, the champions had leadership at the table, and they began to help us with conducting the needs assessment, making sure the data was available, making sure there was trust between organizations to share that data, and then again, adopting the evidence-based practices and addressing stigma that might get in the way of those particular practices. Dr. Avery, you might be surprised that one of our champions in a coalition who was in charge of medications for opioid use disorder did not believe, actually, that medication should be allowed, that he believed primarily the behavioral health and counseling was the #1 strategy. So eventually this particular coalition asked him to step down from his championship role. We did require that the action plan include strategies and evidence-based in healthcare, in criminal legal, as well as behavioral health. Now, each of these has venues that were incorporated. For example, in criminal legal, it could be probation, it could be the jail, could be the police department. Lots of different strategies in each of those venues, and the same with healthcare. Could have been an ER, hospital, could be medically supervised drug treatment. And in behavioral health, could be harm reduction, could be a homeless shelter. Those were engaged in the 3 different primary practices of the menu, which are overdose education with Narcan or naloxone distribution. Second was medication for opioid use disorder, which meant expansion of access to medications. It meant linkage to, and then retention and engagement in care. And finally was the safer prescribing, which meant really reinforcing guidelines around safer prescribing, but also dispensing. For example, drug take back programs, again, in drop-offs in drugstores. You're very familiar probably with this continuum of care approach. You'll see here in the middle is that primarily we're looking at people already at risk for opioid use disorder and those who have progressed with a disorder, making sure they're in care, have access to care, but along the way that harm reduction was applied and accessible for them. So you're going to hear a lot for those who stay for the training in just a moment around naloxone distribution. I remember my colleague Sharon Stancliffe, who is now at the Department of Health in New York, in 2005, she taught me how to inject an orange to practice on injecting naloxone. Today, we have, of course, a nasal, we have intramuscular muscular injection use, and those are widely available. And as of last year in March, naloxone is available over the counter with a non-prescription. So as you're going to hear much more about, it restores normal breathing within 2 to 3 minutes. It has moved from early stages available as only provided by medical providers to in In 1996, it became available for community access to Narcan. And we're very proud of the Chicago Recovery Alliance for beginning to do that work way back in 1996. So overdose education is combined with the naloxone availability, including making sure that people use rescue breathing, as well as calling 911 in the process, and making sure that because we have Good Samaritan laws, you know you will be protected if you use this particular device and or intervention. So why do we use medication for opioid use disorder? You just heard the description of those from Dr. Avery. Again, they have impact on reducing suicide, even cancer, drug-related issues and comorbidities, alcohol-related, cardiovascular issues. But I want to highlight both during incarceration and post-incarceration, when medication for opioid disorder is available, the risk for overdose is reduced drastically. If you compare us in the US to other of our neighboring countries, those with overdose rates per 1 million population, sadly, we rank at the top. Where do we rank when it comes to access to medication for opioid use disorder? At the bottom. So what are we doing wrong here? Some 2.5 million people in the US were actually diagnosed with opioid use disorder. 35% received any substance use treatment at all, and only 20% of those received a medication for opioid use disorder. So we have a long way to go in increasing access, and we learned a lot through COVID that we can expand the access through telepractice, take-home dosing in methadone, for example, or mobile services that are now becoming more available. When it comes to safer prescribing and dispensing, again, making sure that providers and those clients and patients who are receiving medications are aware of the risk of overdose due to prescribed, as well as making sure that we get rid of those medications that we have not used. Look at the rates here. 8.15 million people misuse prescription painkillers each year. And where do they get those painkillers sometimes? They get them from a friend or from a relative, right, who hasn't used those medications. Communication campaigns are central to this. How do we get the message out around naloxone? Dr. Avery talked about interventions when it comes to reducing stigma. Messaging and using social media are really critical. We use those this particular in our campaigns, reducing, increasing awareness in naloxone, talking about treatment and substance use disorder, awareness of where treatment can be found, but also increasing awareness of fentanyl and its impact on the drug supply, especially as we saw it escalate during COVID. The audiences are actually people with lived experience, people using drugs actively, those who are in and out of care, but also providers, as we heard that healthcare providers also have some of the highest rates of stigma. Very creative work in communities, everything from on sides of buses to billboards, coffee cup holders, again in social media, Facebook, Instagram, and other places, really engaged community organizations with health departments to be able to get the message out and in multiple languages as well. The number of strategies implemented in our communities, as you see, 615 of the strategies in wave one, and across you'll see the distribution between the 3 different evidence-based practices here. Some of the early lessons learned from from here in New York, as you see across the state, we were all the way out in Chautauqua next to Buffalo. We were also in Erie, but also over there in Long Island and Suffolk as well. And we were way up in Lewis. By the way, they said, we can't believe you came to us to do research. No one ever comes this far north, right? A small community with 20,000 people, or in Yates, our other small rural community. And then Sullivan, of course, sadly has the highest rates of overdose in New York State. Often they feel skipped, they said, because we're not close enough to the Hudson River. Again, coalitions. 520 coalition members. If you get a sense of them, I attended about 400 of these coalition meetings, was able to hear and listen and participate together. And in New York, 290 strategies that were implemented in all of these campaigns, 64 grassroots tailored campaigns that were implemented. What's so exciting is those campaigns, the strategies that were sustained. 103 of them were sustained. So we know we had an impact on promoting and the adoption of evidence-based practice because we know they were sustained. Again, when it comes to the actual campaign, look at the number of click-throughs of these particular campaigns, 161,000. 41 impressions, meaning someone actually went to the actual message to check it out, right? So there's a lot of people who are seeing these campaigns. We have the opportunity here to reach a lot of people if we continue to do these kinds of efforts. Using data is so central to the work. We use really advanced modeling data here that our Columbia University IT division helped us with, and our partners at NYU developing and at Einstein developing models that told us not one evidence-based practice will work, but a combination of practices must be used in order to address the opioid crisis. We were able to visualize those in community profiles and then on dashboards that were available for decision-making all along. We know our coalitions were sustained as well. 7 out of 8 of Wave 2 coalitions were sustained, and in some format, all 16 of our coalitions in New York State were sustained, along with our teams that we had paid for. They were able to find new resources for those team members. The data coordination was taken on as a priority in communities, and health equity began to be a priority in communities, even though it had not been from day one made as a priority in our work, but we learned a lot about the importance of this. I want to really finalize, talk a little bit about some of the things that were sustained with visualizations. You saw communities develop their own websites and dashboards. They actually were tracking where were the naloxone boxes, where were the overdoses, and how they overlapped. They were doing the monitoring and evaluation of where the kits were being distributed. Again, the types of programs that remain were things like working with the police around leave behind programs, leave behind naloxone for those who had overdosed and survived. Kits continued to be distributed, bars and restaurants engaged. Law enforcement engaged. We're very proud of this particular approach that now has been funded by 3 different funding sources. Almost $2 million, where law enforcement, social work, peers come together to address an overdose with linkages to care. You see the linkages here range from rehab to detox, also housing and recovery. We're a part of the approach. We also put up many naloxone boxes where those kits could be captured without any access to reduce stigma to even asking for a naloxone box. We're very proud of this one community of 8,000 in Rochester, Monroe County in Wave 2. Vending machines, a new innovative approach where harm reduction supplies, safer sex kits could be included, and even things like toothbrush, again, and health kits could be included along with Narcan in those particular naloxone vending machines. We're very proud that we launched, actually helped launch 2 different methadone programs, opioid treatment programs. This particular one addressed some pushback in the community, and in the next week or 2, we're actually waiting to have a very celebratory launch, even though they've begun the mobile services already. So by engaging the community, they were able to address some of the stigma that was addressed from opioid stigma toward methadone. Again, the kits that can come out of a vending machine can range from Narcan kits, fentanyl test strips, xylazine test strips, or safer sex kits, as you see here. We're very proud that Cayuga County was honored through the PBS special. I ask you to check this out. This particular county reduced overdose deaths by 40% during the intervention period. We're very proud this continues today, and they are partners to dissemination of the efforts that we've done. So do check out this particular PBS special. Finally, we have the opportunity to capture and to devote resources from settlement funds, from pharmaceutical settlement funds, New York State specifically up to $2 billion, already 192 million allocated. We have been a part of the decision making with the advisory board. We've been training on the communities that heal intervention, and the actual primary goals of the settlement funds and the advisory board match perfectly onto this particular intervention, which is about getting Narcan out there, getting medications out there, for accessing those, treating co-occurring disorders with mental health and substance use together, and making sure people who are most vulnerable are being treated with either treatment or harm reduction supplies. So finally, a really excited outcome here of our work has been the reduction of stigma in the perception of stigma among our communities. As you see here, surveys were implemented, over 1,300 surveys from our communities, and we saw a statistically significant effect on perception of stigma toward opioid use disorder, as well as stigma toward medications for opioid use disorder were reduced among our intervention communities. And more specifically, among those urban communities, we saw a better reduction in stigma. So we're very proud to see this. Check out this particular article. And so some of the take-home messages, and we look forward to your questions today and questions of interest. We know that our intervention can reduce stigma. We know that evidence-based practices take time and that we probably needed more time than the intervention period allowed in this particular study. We know a combination of strategies is needed, where harm reduction and treatment is needed, and retention strategies very specifically are needed. Our measures may not have captured all the good work of the intervention around coordination, around data utilization. COVID had a huge effect on our work of galvanizing efforts. I was amazed that people came together during COVID and addressed not only COVID deaths and risk, but overdose at the same time, where you saw medical examiners sitting in a coalition meeting talking directly about who was dying from an overdose. And the coalition was addressing it directly with their chief of police, with their fire departments, with their faith-based organizations, and with those people of lived experience. Again, our communities stand ready to use data-driven approaches. They are ready to use evidence-based practices. They are ready to partner with social work and with professions like other allied professions to do this work. I hope that you're inspired as researchers to do more of this. I certainly have. And I never thought that I would actually come into this field, Dr. Avery, either. I had not planned to do addiction work. I've been doing treatment for over 35 years. My first job out of school was at an alcohol and drug program, a mental health program, and an HIV/AIDS program. And who knew that also in my own family that I would have 2 fatal overdoses in my own family during the course of my adult life. So we never know where it's going to hit. These particular program managers say, look, the study has ended, but the work continues. They continue to be inspired by the work that we've been able to bring to them. We hope that you can, again, access the resources that have been available. Check these out at SAMHSA or our websites. You can see our protocols, our practice guides that are used for community engagement. And if you have additional questions, I'm certainly available, and I know we're going to hopefully be able to answer more questions today. Thank you for the time.
Thank you both very much. I'm blown away by all the work that you're doing. And one thing I know is that I know in one way how to tell you've been effective, because I saw a delivery bicycle who had a naloxone kit. So I thought that was very good. And I think every delivery person should probably get one. So my name's Susan Nayowith, and I'm a proud 1984 graduate of the social work school. I do see, by the way, I saw on the list that Eric Stam is on there. Eric, it's been about 40 years, so I'm happy to see you today. I'm happy to be part of this committee. We have a great committee. And so I'm going to just jump in because we don't have a lot of time to the questions. And so I think one of there's a couple questions, some overlap, and they were asked before you gave your presentations. But one of them that has repeated itself is about the harm reduction methods in place and how do you sell those methods to active addicts and their families and the community. If you have a strategy. I like the idea of the technology. I love the idea of the vending machines. I think that is brilliant. I also like the idea of the empathy. I think I want to take that class on empathy, but.
I mean, I can start with some thoughts. I mean, first, it was wonderful
Sure.
to partner with Dr. Hunt on this, and it was a Herculean effort to each do 30 minutes, and we did it. But I think we're both, I think, have the same answer and the same goals by whatever means necessary to get harm reduction tools out there. And I think you need a whole menu for everyone, you know. And I think I like having it where you just have no barrier to pick it up at all. It's over the counter now, or you can get it in one of the boxes. I found it effective, in addition to the social media messaging, to pair it with personal stories. And so, you know, when we go into high schools, or, you know, part of the reason John and Robin come with me to all the Narcan trainings, the one we're about to do, is that I do think coupling it with a story that resonates and connects people to the issue can also be very effective. But like other harm reduction things historically, from the seatbelt to condoms, you know, there are all sorts of, you know, barriers that people put up at times. But I think Dr. Hunt and I are trying to break down those as in any way possible.
Okay. Okay, so the next question is, are there other roles that a psychiatrist has in treatment of opioid addiction besides psychopharmacological or prescribing medication?
I mean, I can tackle it first, but I hope so. You know, the treatment of opioid use disorder, I think, starts with providing the evidence-based medications and harm reduction strategies, but it also addresses the why people use, and addresses co-occurring disorders. And, you know, no one recovers alone. And so you need to do it, you know, as a family, as a community, and with other resources, from therapy to different groups. And so while the meds are necessary for a good outcome, you know, they're not sufficient. We need all bunch of resources, and Dr. Hunt described the different ways to get all these different resources in people's hands.
I mean, I could respond not as a psychiatrist, but a clinician, and sadly, sometimes psychiatrists have been relegated to medications because just there's not enough of them around to do that work. So we tend to have more, you know, counselors or social workers. But I have to say, I'm also serving on a SAMHSA workforce task force right now, national, and there's a real crisis in our nation of those who are not entering the field of addiction. There's a crisis, and COVID, there are many people left the field in general since COVID. So I would invite any of you who are interested or know people in your family who want to go back to school or be certified in addiction care, that we need you. And it needs a combination of strategies. Certainly availability of medications can be the treatment, but also a combination of treatments is shown to be effective as well. And it's not just the person with the substance use disorder, it is their family members. I'm about to see a father in just a few moments who actually saved his son with Narcan from an overdose. And so it is those families, those other people who are touched by addictions that we can care for as well.
Thank you. Okay, another question. Do you know if anything is being done to protect pain patients with legitimate prescriptions from being treated like criminals by the healthcare system?
We've struggled to have to be nuanced about pain and pain medications. I think that needle's just swung back and forth in a way that's not thoughtful. I don't think anyone in the addiction field is necessarily anti-opioid for pain, yet sometimes people hear about these deaths and they withhold opioids in really critical settings, like for acute pain or cancer pain or end of life distress. Whereas where opiates are uniquely able to help in those settings, and you know, I have seen people get abandoned by providers or not take available treatment because of concerns. And so that is important to protect pain patients and their needs. But we're cutting down the prescribing because there was a lot of bad practices and meds were greatly overprescribed. And so hopefully we can get to the right degree of treatment.
Thank you. Okay, another question. Which areas of our system of healthcare can be most important in changing stigma? You talked about hospitals, talked about the community. Are there particular sort of entry points?
Yeah, well, I think as Dr. Hahn was mentioning, there's no addiction psychiatrists. There's like 1,000 addiction psychiatrists in the whole country, like 3,000 addiction medicine providers. And so I think the onus is on all clinicians wherever they're meeting the patient. And I've been especially focused on sort of frontline folks, you know, ER docs, pediatricians, internal medicine. But that would include, you know, social work. I think a lot of people's first exposure may be coming to see any one of you, and it's important to be aware of what the treatment should be and aware of our attitudes as we interact with those folks. And then it extends to all frontline responders, to people in school, to lawyers, as I mentioned, you know, to families. So I think it's really those people that you're seeing on the regular that have the most chance to impact change than necessarily in the hospital setting. And so I do focus on those, but the whole system needs help every stage along the way.
And I would agree also, you know, primary care is a great opportunity. Again, that every provider sees the opportunity to hear and screen for substance use disorder in an empathic, non-judgmental way, right? And I remember actually my mother had was in a rehab after she fell and broke her hip, and I witnessed the nurse ask my mother, who was 90 at the time, going through a battery of screening. She said, "Do you use crack cocaine? Do you use heroin?" And my mother was like, "What is crack?" Right? But it was the way this nurse was asking, you're like, I wish she had had some training, right? How do you ask these kind of questions? So really normalizing the questions, making sure that the providers know where to send people as well.
One last question would be, where can people find resources for different ethnic groups or even languages?
I mean, look, we've not done a sufficient job in developing materials and engaging people, leaders and decision makers and advocates for communities of color, for communities that have been minoritized. We have to do a better job. So I would first go to wherever you are in your community, go to those leaders, go to people with lived experience, go to the people who use active drugs actively or in recovery, and listen to their needs and what they see as a priority. I think that's really the most important lesson. But certainly SAMHSA, you can go to the SAMHSA websites and find a variety of materials. The ATTCs are good for training materials. SAMHSA has the Opioid Response Network. If you can, these are free services, free technical assistance, so you could go there for additional services as well, and training needs.
Thank you. Sue, feel free to jump in.
Yes. As my fair lady said, we could have danced all night. You know, we could go on and on. There's so many questions and such a wonderful talks. And unfortunately, I have to move us forward. But first of all, John, I want to thank you for your wonderful remarks about our collaboration and friends and professional at Cornell, which has been very cherished by me. And I'm so thrilled to bring you to my other professional home. And Dr. Hunt, I just am thrilled to have a kindred spirit in my profession And I'm thrilled that this event brought us together. It's just an absolutely wonderful presentations by you both. And in my work, which is much less than in addictions, but the stigma, but also countertransference. We didn't use that word so much tonight, but the feeling of discouragement, you're both so inspirational. You know, you just motivate us to learn more and get more training and education ourselves, and not feel despair and hopelessness, which I think sometimes these clients can elicit, as well as their families. So thank you so much. And please stay on, because now Dr. Avery is going to walk us through training and with some parents that are here to talk to us also, right, John? You'll
That's right.
introduce-
No, thank you so much for inviting us both. And
Thank you,
Dr.
everybody, for participating. And
Thank
stay
you so
on.
much.
All right, and so now I'm grateful to welcome John and Robin to join us here. Thank you both for coming. This is we're gonna do a Narcan training, just 10 or 15 minutes more, and everyone at the end, if you can hang on, are gonna receive this naloxone rescue kit pack in the mail. And as Dr. Hunt and I are mentioning, this is a critical intervention in the setting of the opiate epidemic, one that we all need to have available. And, you know, I've been lucky to partner with John and Robin to give these kits all around the city. And, you know, we've been to bars and clubs and street outreach and anywhere that they'll have us, schools. And, you know, there's been a lot of barriers to harm reduction as we were starting to talk, but anywhere that we've done them, we've really seen the impact and we've seen the lives saved over the years. And to highlight why this is so important, I'm going to turn it over to John and Robin to share their story and Zoe's story. And then after, I'm going to walk you through just a couple quick minutes on how to use the kits. So John and Robin, I'll turn it over to you.
Thank you, John.
Thank you, and thank you for this opportunity. I feel inspired after listening to this talk as well, and hopeful. You know, when Zoe, well, first, let me just show you quickly. So this is Zoe, beautiful, smart, kind of the girl who knew better. She went into her bedroom on April 9th, 2007, and she took an accidental drug overdose, and at 22 years old, she lost her life. And we knew nothing. We knew nothing about Narcan because nobody was talking about Narcan, but also we came up against what Dr. Avery and Dr. Hunt were talking about, which is that the stigma within the medical community was great. And it really was an obstacle in her getting the proper care for a health condition. So we wasted a lot of time. And by the time Zoe had finally agreed to going into treatment, and she had an appointment on a Thursday, but it took us about a year and a half to get to that point. Really just trying to figure out who we should see, who was going to help her, who in the healthcare field was going to provide us with answers that had to do with medicine and science. When she finally did agree, the weekend before that Thursday, she went out with her friends, as she had done many times before. And that night, that one night, was going to be different than all other nights. And she went into her bedroom and she took a combination of drugs that were probably adulterated, that slowed her respiration and stopped her heart. And she went to sleep that night thinking that she had done this before. And I knew she was using drugs and misusing drugs, and I wasn't condoning it, but we did have an appointment. But, you know, as can happen with this particular health issue, she made a mistake that night, and it cost her everything. And that doesn't have to happen. Overdose deaths are preventable. Nobody has to die from a drug overdose. And that's what we're trying to reinforce. So we believe that everyone, everywhere should have Narcan. I carry it with me I never leave the house without my Narcan, whether I might find myself in a situation where somebody does overdose, or I see someone on the street who might know someone who could use a kit. I never leave home without it. And our goal is that everyone will one day have Narcan at home, in their businesses, and in school, everywhere.
You know, Narcan really is a wonder drug. You know, what Narcan does, as you know, is if someone's ingested an opioid and their respiration is slowing, their heartbeat is slowing, and there could be a few minutes from dying, administering Narcan will almost instantly reverse an overdose. You know, our Robbins and my niece had a very good friend, lived in San Francisco, graduated from college a few years ago. This is about 2 months ago. He and his roommates got some cocaine for the weekend, did not know it was cut with fentanyl, used the cocaine, and he's dead. They had no Narcan there. But there are other stories, really wonderful stories. Robin, our two friends.
Two young friends of ours who we were somehow did a distribution, Narcan distribution, and they carry their Narcan all the time. And they both on separate occasions came upon someone who was unconscious on a subway platform, and they remembered everything from their training. They called 911, they whipped out their Narcan kit, and they saved a life. And these are just, it's you and I. And that's what this is really about. And that's the reason that John and I are here, because we think that this happens to someone else until it happens to us. Well, we are those someone else's. And if it can be us, it can be you. So they are just heroes in my mind. So today's heroes carry Narcan.
You know, my mother used to have a saying when my brother and I were young. She used to say, where there's life, there's hope. And that's exactly what Narcan does. If someone is close to dying from an opioid overdose and you administer Narcan, they live. And there's hope that if they have an addiction, they'll get into treatment, that they won't make a mistake again. They'll have Narcan with them if they're going to use again. And so what Narcan does is it enables someone who might otherwise have died to live and have hope for the future. And
it's also, I think, an incredible message. So if somebody comes into an emergency room and they've overdosed and they leave with Narcan, the message is that what you're doing is really dangerous. And in fact, it can kill you. So we're going to give you this medicine that can save your life. And I think that Narcan in itself is a really important message for anybody that uses drugs. I know Zoe certainly didn't think that what happened to her was going to happen. And neither did we.
Right. So, John, thank you for everything you've done. Thank you all for listening and being interested. You know, John told us once that of all the Narcan kits distributed, somewhere, I can't remember the exact number, John, somewhere between 15 and 20% are used. So if there are 50,000 Narcan kits distributed in New York City, somewhere between 7,000 and 10,000 of those are used, which means
lives saved.
Now, maybe every person who overdosed wouldn't have died, but some would have. And as Robin said, please carry it. Have it in your purse, your pocket, your jacket pocket, whatever. The fentanyl crisis is not going away, and it's making the situation much more dangerous and worse.
You, John, Robin, for sharing your story and Zoe's story. I always carry Zoe with me as I do this work, and it's for her and with you guys that we do this work. So I'm very grateful for you coming today and always doing this with me. And I confess I often borrow John's statement because I think it's at the heart of this intervention, is that where there's life, there's hope. And Narcan really is an intervention that can keep people alive and really help. And so afterwards, I know they're trapped on campus with the protests, the kits I sent over, but we'll get them to you in the coming weeks. We'll get each of you one of these kits in the mail. They're also available now over the counter, which is the beauty of Narcan. Dr. Hunt said that since last summer. And so you can pick them up over the counter. You can send your patients to over the counter or to a number of places, like here at Presbyterian, where we give them for free. And there's an app, Stop OD NYC, which also has a link to all the places you can get them for free. They're about $50 at CVS or online. But we'll all give them to you afterwards, and they're super easy to use. And again, we sort of covered most of the training in some ways in this talk, but Narcan is an opiate overdose spray. It's an opiate antagonist. It goes to the brain, knocks the opiates off the receptor. And again, opiates are things like heroin, but now fentanyl. as well as, prescription meds like Percocet, Vicodin, on down the line. And the reason that it's over the counter and the reason we can give this to you all is that it's super safe. So it doesn't rescue you from any other type of overdose if you're overdosed from any other drug or had a heart attack or anything else, but it does no harm. So it doesn't impact you if you're on other medications. The only thing it can do is save your life if you've overdosed. And in that way, it's sort of the only med that I think that you can get over the counter or get for free like this and give to someone else who's not responding. It's sort of an amazing opportunity, as Robin said, to be a hero. And so the training's very simple. So if you see someone who's non-responsive, the first step is to do what's called a sternal rub, which is to rub your knuckles firmly into their sternum, basically see if they're arousable. If they're not arousable, the next step is to call 911. And to encourage people to call 911, Dr. Hunt mentioned there's the Good Samaritan law. It's in New York State. It's also in most other states around the country. And basically that protects you legally to give someone else a medication. And it also protects you if there's less than felony level drug offenses on the scene. They want people to be encouraged to use it without fear of legal ramifications. And so the Good Samaritan law should give you confidence that you can do it and be protected legally. So it's sternal rub, call 911, and then if they're not responding, you'll open the bag, show this to you guys, and you'll take out one of the nasal sprays. And there's 2 nasal sprays in each kit. You'll take it out of the package, tilt the head back, and spray it in one nostril. Anywhere from 10 seconds to 2 minutes. If it works, there'll be a characteristic response, a sort of return to breath. In the setting of the fentanyl epidemic, fentanyl being a really powerful opiate, people are generally groggy. So it's sort of like being woken from a sleep and you just have to say, so-and-so, I gave you Narcan, you're safe and you're okay. If after the first spray, they don't respond, there's a second spray in each kit. And then you can spray that in the same nostril or the other nostril. And sometimes 2 are required in the era of the fentanyl epidemic. If they're still not responding after the second spray, you put them on their left side in the recovery position. And you put them on the left side to avoid people getting anything in their lungs if they were to throw up or something like that. Super simple, easy to use. See if they're arousable, call 911, spray in one nostril, wait 2 to 5 minutes, spray in the nostril, then put it on the side in the recovery position. And as I said, it's totally safe. If EMS is coming to a scene these days, often the first thing they do is give the spray. Because they don't know if they overdose or not. And I don't want you guys to feel like you have to be a detective. Just give it. There's no harm, as I said, which is why it's over the counter. And I think Dr. Hunt and I made this clear in the presentation, but there's also no harm in it doesn't encourage substance use. I think that's the worry with all harm reduction efforts, that seatbelts will encourage fast driving or condoms will encourage problematic sex. But just like with those things, it protects the person, and most overdoses are accidental. People want to live. And so it provides an opportunity to get someone a life-saving medication. And John and Robin, did I forget anything from the normal training?
Nope, nothing that we think of.
So that's it. That's the training, super easy. There was a good question. When would you do CPR? CPR is not a part of this training, intentionally so people don't feel nervous about this intervention. And for CPR, if you know it, you have to be a little detective and understand their pulse and everything else. But if CPR is indicated and you're trained in CPR, you do it after the first spray. So they're not responding, call 911, spray, and then you can begin CPR measures. And that's the step that EMS, the ambulance people, take often. And again, if they're down from a heart attack or another reason, still okay to give, won't impact their course and can only provide safety. Another question, thoughts of how to handle if others are around or if any resistance from others about administering? So a couple good points. One is that sometimes people are nervous to approach people. And if you are, we encourage you to call someone over to come up with you. There are gloves as well in each kit. There's also, if you forgot how to use it after this isn't you can review it. There's instructions again. And so don't feel deer in headlights. You can, in the kit, there'll be a reminder of how to do it. And then it's a good question if someone's there and they don't want you to give it. In that way, I would just call others around and explain what you know about overdoses and the safety, and do what you can to administer it. I think the other worry is that people will wake up agitated in this setting. But again, most people wake up groggy. They're relieved to be alive. Again, half these overdoses are people who didn't even know they were taking an opiate, right? They were trying to use another substance or got accidentally exposed. And so they're grateful to be alive. But yeah, some people are worried about it. It's weird to have, and that's the unique thing about this med. You're doing a medical intervention, even if you're not a medical professional, on someone else that you can buy over the counter. And so there's some nervousness at first. There's nervousness for me. I did my first one after going through medical school and residency. I remember being nervous the first time I administered it. So it's understandable, but I would say don't do it alone, and have someone with you if you can. What information would you share with the recovery community on why medical assistance is a good option to help someone with a substance use disorder who's new in recovery? I think this means why do you recommend more than sort of like 12-step or social supports? And I think that's a great question. And, I think historically, the treatment of substance use disorder has been very non-medical. Go see someone else, go to meetings, or go see someone else about this, the doctor saying that to a patient. But these days we recognize that there's a lot of interventions that medical professionals can provide, certainly psychiatrists and therapists and social workers providing therapy to understand the reasons why. And then there's an increasing menu of medications expanding, by the day, that can provide assistance to, in the setting of opioid use, to sort of keep people alive. But there are a lot of other meds for for other substance use conditions that can improve outcomes. Like with any medical issue, you want the best evidence-based care, and you want to be presented with all your options. So even if people are suspicious or unsure, it's helpful sometimes to just have that conversation with a medical professional. It doesn't mean you have to do it, to just understand your options and know that you're not alone, and good treatments exist. And Narcan sometimes is the introduction to that conversation. We've had a lot of people that aren't motivated to seek help. We give them Narcan, and they don't use it, but they remember, because there's links in this to care, that there help's available, that good treatment's available. So a lot of this Narcan isn't even about saving lives by rescuing them with it, but about connecting them with care, reminding them to be safe, and reminding them that good treatment options exist. The next question is there resistance to the use of fentanyl strips? What is the basis for that resistance? As well as a lot of thank yous to John and Robin in the questions for coming and sharing their stories. Fentanyl test strips were sort of the last harm reduction effort approved. It took the Biden administration a long time to throw their support around it. Sort of along the lines of people being reluctant to do harm reduction. There was the thought that it would encourage people to seek out more contaminated product, I guess, or product that is more potent, or give them sort of a false reassurance that they can use safely when it's not guaranteed. All of that is wrong. There's pretty strong evidence that it saves lives. People that use the strips know not to use alone and have Narcan handy. It highlights risk where people sometimes aren't aware of risk. But similar to some ways having Narcan, it's asking you to be a little bit medical, right? You have to take a little bit of the product, put it in water, dip it, and when you get one, you'll see the instructions. And it feels challenging, but in fact, it's super easy. And that was sort of what I was trying to convey with the Narcan, is that it looks challenging or complicated to give a medication to someone, but it's actually all you're doing is spraying in people's noses. And Dr. Hunt mentioned some places you can just get it out of a lockbox. You can get it over the counter without training. So if you remember nothing else, it's take it out of the package, spray it in the nose, and that's it. And the fentanyl test strip really is just about, testing a little bit of your product. That looks like all the questions.
I think we're okay. So Robin and John, I'm a family therapist, and Dr. Avery knows that I don't specialize in substance abuse disorders. I've had some experience, but I am a family therapist and deal with a lot of loss, sometimes by suicide. So I've had a lot of experience. But I have a Jeremiah, and if he had been a girl, Zoe was the name that I would have picked. So I don't often run into such courage to transform your grief and loss into helping us all do better. You know, all of us, to learn from John and Dr. Hunt and to do better by all of you, especially as a family clinician. I do get a lot of calls about the failures of the mental health system and the access problems and the insurance problems. And a lot of people don't get to meet a John Avery in their life, you know. So I just want to thank you so much for being with our community at social work school tonight. And John, I don't know what to say. I mean, you are what you are. It's why I asked you to come. And Dr. Hunt as well. And thank you for everybody being with us and staying the course after a long day for to learn so much. I just took reams of notes. I'm sure everybody did. And to feel hopeful that we just have to go back to the drawing board and work harder to save lives. That's just what it is. And thank you so much, John, for doing the training. And it feels a little phobically anxious to try it, but you help us try to go ahead anyway. Okay, have a good evening, everybody. Stay safe and feel inspired. Hold on to this evening for as much as you can. Take
Thank you,
care.
everyone. Thank you.
Thank you.
Bye-bye.